Good morning. Thanks for having us. We're certainly proud and honored to be here today. My name is Dr. Michael Curran. I am the CEO of Greater Boston Urology and also work with Dr. Gevin in our Advanced Therapeutics Center for patients with metastatic prostate cancer. And my role today is to provide a little bit of background on what an integrated urology practice is, which is the type of practice we are, and also to inform you and hopefully get the message out that there are a few things going on in Washington, D.C. that we're very involved with, and we really think it's important that patients understand and know. So we work with a national organization called LUGPA. LUGPA is a national association of what are called integrated urology practices. So what is an integrated urology practice? An integrated urology practice tends to be a practice that covers a large geographical area, has multiple physicians who formerly were in different group practices but have joined into one group practice. And our purpose is that we believe that it is very important to have proper integrated care for the urology patient at the community level. Why is that so important? Well, it's pretty simple. We see the majority of patients who have prostate cancer or any other urologic condition. The academic centers are wonderful. We thank God every day that they're there, but they have different focus than what we have in the community. They have patient care responsibilities, educational responsibilities, research responsibilities, teaching responsibilities, publishing responsibilities. Our job in the community is to take care of you folks, and we're very committed to that. And this group LUGPA at the national level decided about 15 years ago that it was very important that we coordinate our efforts so that as we have all these doctors that we're actually providing the care that the patients need at the community level, such that we're not overburdening our academic centers because they need the time to do research to give us the next line of therapies that we can offer to the folks. And we also want to make sure that we're providing the services in a way that is cost effective and high quality. So by doing this, we're able to pool resources that we never could before and offer things like a metastatic prostate therapeutics center that can concentrate on bone health, like you'll hear from Dr. Geffen today. So that's kind of who we are. And there's several issues in Washington, D.C. that we're also very involved with at the national level of LUGPA. And we get really involved with patient advocacy, physician advocacy, and again, the central theme and the mission of it is to make sure that patients in the community have access to high quality, efficient, cost-effective health care. And one thing that we do, and one thing that our group in Greater Boston Urology that has won national awards for, is going down to D.C. and talking to your congressmen, talking to your senators, and making sure that at the national level, your interests are being looked out for. We believe that there's a responsibility on us as physicians to make sure that somebody is down in D.C. standing up for the patients side by side many times with many of the patient groups advocating for what we need for prostate cancer and for your care. So the two issues that I do want to bring up for 2016, one is a little bit of an old issue that has a new twist, which I'm sure you've all heard about, which is the United States Preventive Services Task Force. And this is a group that tells us what do we need to do for screening of multiple conditions in medicine. Prostate cancer is a condition in medicine. In a decision they made back in 2012, they gave PSA screening a D rating and started really a firestorm, not only in medical communities, but it also was very, very prominent in the media about prostate cancer not being a serious disease. People don't die from it. There's no need to screen for it, et cetera. And as we all know in this room, that there's a handful of patients who are lucky enough to have a prostate cancer that is not a cancer they are going to die from, it's a cancer they're going to live with. But that cancer is no less serious than any other cancer. And to have a United States government body come out and give a recommendation that kind of says prostate cancer isn't important just doesn't sit well with patients, doctors, and we need to fight back against this, because who it sits well with is the people that have to pay for the test. The good news is, due to primarily groups like yourself, the doctors we tried, they didn't listen to us. They listened to you folks. They just announced they're going to re-review this decision. And there's really two primary reasons why. The first decision never took anything into consideration on risk factors. And those risk factors comprise a very large segment of the male population in the United States. African American men get prostate cancer at higher rates, with a more aggressive form of the disease, and have higher mortality rates. They need to be screened. There's no ifs, ands, or buts about that. The initial D rating did not take that into consideration. Number two is family history. If 1 in 6 men are going to get prostate cancer, how many of their male descendants are at risk and also need to be screened? And in that population, there are no ifs, ands, or buts about that. So this may not sound like much, but the fact that this task force is now going back and reconsidering their original recommendation is kind of a big deal, and you folks need to know about it because it's groups like this that got that done. The second thing is something that's being handled more on our side, on the physician side, but it will have an impact in patients. And this is a CMS, which you can also substitute the word Medicare, pilot study or a test for Medicare Part B prescription drug models that is being pushed by the Department of Health and Human Services to CMS, and unfortunately no congressional oversight is needed to implement this pilot study. The statement is that it's to improve the quality of care and deliver better value for Medicare beneficiaries, is what the program is. So what is this? What does it mean? This is a pilot program that is going to look at drugs that are injected or infused in doctors' offices for a multitude of conditions. There are many drugs that will fall under prostate cancer that will be affected by this. The current way that Medicare reimburses the physician's practice or hospital for these injections is to take an average of the wholesale price of the drug, they add 6% to it, and that's what the entity administering the drug, usually a private practice physician, gets paid for it. And that's a system that right now, many of us in medicine aren't necessarily happy with that, but that's how it is. The new pilot would take that and change it to average wholesale price plus 2% and $16 to cover the cost of essentially a needle and IV tubing and maybe a syringe. The problem with this is that it's going to really destroy patients' access to non-generic medications. In the prostate cancer space, all of the drugs we're giving to patients with prostate cancer that would fall under this have no generic equivalent. So that 6% that they're trying to save money on is really what we need to be able to provide those medications to our patients. And who are these patients? Well, these are the patients with advanced prostate cancer. And they have a multitude of problems, and these patients have the high likelihood of dying from prostate cancer. So what we've done is we're fortunate in Massachusetts that we have a congressional district with Representative Neal, who penned a letter to CMS saying this is a bad idea. And one of the big points of emphasis is because of how many men will be affected with prostate cancer for this. At the time that Neal wrote his letter, he was looking for signatures from congressmen in Massachusetts. And because of LUGPA, our national group, and our group in Boston's connections with Representative Kennedy and primarily Representative Lynch, and working with a gentleman out of a company called Gateway Public Solutions, we were fortunate enough to, in a matter of 10 days, get all congressional representatives from the state of Massachusetts to sign Mr. Neal's letter saying this is a bad idea, because we think it's very important to preserve access to these medications for prostate cancer patients. The unfortunate thing is the letter in the Senate supporting this act was penned by Senator Warren, and Senator Markey just signed on with her for that. So we have a split between our congressional representatives and our senators. But if you want to do something that can help preserve access to care for prostate cancer therapeutics, write a letter of thank you to your congressman, because they are all on your side.